So welcome everyone. This is the second youth session or breakout session for today. So I, let me introduce myself. So my name is Paul Geraldo Ye. I am a professor with the School of Public Health in the Department of Management, Policy, and Community Health. Um, and it's interesting because I'm in academia, so I'm used to teaching in big lecture hall classes, and there's this always happens where every time I'm speaking, the first two rows, you guys just moved, but the first two or three rows, like there's like a, I feel like it's what is it, like the splash zone at like SeaWorld. Like no one wants to sit in the front for some reason, afraid that I'm gonna spray them with my saliva or something. But anyways, I'm glad that you guys have all joined us today. And so let me introduce the panelists that we have. And I'll introduce them in the order that they'll speak. So this will be, I know everyone has kind of done different styles of breakout sessions. This will be kind of more the traditional style where each of the presenters are going to talk first about a topic, and then we'll open up for discussion towards the end. Um, so first we have Ms. Karishma Mendez. And so Ms. Mendez is a licensed professional counselor who's dedicated to holistic mental health and wellness. And so Ms. Mendez received both her bachelor's and master's degree from St. Thomas in clinical mental health counseling. And she currently works as a counselor at Sacred Minds Counseling, and you also volunteer at Charlie Health. Is that correct? Okay. So she does a mix of cognitive behavioral therapy, person-centered therapy in a culturally competent manner, and some clinical areas of expertise amongst a lot others, but I'll just list a few. So trauma, peer-related and academic challenges, career counseling, anxiety, depression, and crisis intervention. That's Ms. Mendez. And then next we have Dr. Lin, who's with us remotely. Dr. Lin is a clinical assistant professor and licensed psychologist in the Department of Psychiatry and Behavioral Sciences at Stanford University. I hope I'm getting all these titles and affiliations correct. Please correct me if I'm wrong. Specializes in providing culturally informed psychotherapy. I hate the way I sound on microphone. Sorry, I just realized. For the treatment of emotional dysregulation, trauma, and eating disorders through the Stanford Mental Health for Asians Research and Treatment Clinic. She also does DBT or dialectical behavioral therapy, as well as eating disorders clinic. And she's interested in diversity, equity, and inclusion, or DEI, which, as you guys know, in the state of Texas, it's becoming something that's more controversial. In clinical training and professional settings, is active in administrative and educational DEI efforts within her department. And last but not least, we have Dr. Yen. Dr. Jennifer Yen is a board-certified child, adolescent, and adult psychiatrist who's affiliated with the Department of Psychiatry at Baylor. And she did both her medical school and general psychiatry residency at UT Health Science Center, Houston, and then her child and adolescence fellowship at Baylor. So her areas of expertise includes autism, ADHD, depression, anxiety, mood disorder. She currently works at the Harris Center, and she's published works related to autism, mental health treatment, especially in the geek culture. Is that correct? I just thought that was interesting. And also parenting burnout during the pandemic. And she's also a writer too that's written novels that's been published. And so maybe she'll talk a little bit about that. Focus on love, family, and the power of acceptance. So these are our three speakers. Let me turn it over first to Ms. Mendez. And she's going to talk about first about performance anxiety, combating mental health stigma, and the model minority myth. So let me turn it over to Ms. Mendez.
Well, thank you, Paul, for that wonderful introduction. And it's wonderful to see everyone here today. I want to commend all of you for taking that step to be here today, as well as our wonderful speakers. I want to open up with a quote, and it goes like this: perfectionism is the antithesis to authenticity. Perfectionism is the antithesis to authenticity. And a couple of years ago, we had a very special event that was a little frightening, but quite profound in the mental health movement. And that was the COVID-19 pandemic. How many of you can remember the COVID-19 pandemic? Perhaps you experienced job loss. Perhaps you were experiencing remote work or returning to school, but it was often a time of isolation. So, can anyone define for me what their definition of mental health is? Anyone? Go ahead.
This isn't like a definition, but kind of the boundaries of mental health. I feel like it's not like feeling happy all the time, but rather having the proper and respective emotions to the corresponding events in your life. For example, like if something sad happens and you feel sad, that doesn't mean your mental health is bad, but rather you're having emotions responding to that. That makes sense?
Absolutely.
I think it's a misconception that having mental health is being happy all the time. So, yeah.
Beautiful. Thank you for sharing. You know, when we think of our emotions, we can often think about as energy in motion, but mental health is health and it encompasses our psychological well being, the way we interact with people, and all aspects of our society, but particularly performance anxiety. How many of you can remember when you were 16 years old? What was going on for you during that time? Anybody want to share?
I'm actually currently 16.
Lovely.
And right now I like most of my stress comes from school and like the pressure of pleasing my parents and like the standards that they set and the standards that everyone around them sets, and like that was also like like it's like a very big thing that hangs like surrounds my day and like what I think about and like what I think about. So it's like really um it's kind of like scary sometimes. Like you feel like you might not be like good enough, or you feel like you might not achieve what you're supposed to be achieving. So like yeah.
Well, thank you, my dear, for sharing. That is amazing that we have you here today. Thank you so much. But exactly, these are the years, especially the teenage years, where it's always about identity development, finding out who you are. And with the AAPI youth, there might be a lot of that pressure, but there's also biculturalism. Think about, okay, for me, I'm in Texas, so I'm a native Houstonian, but I'm also South Asian and I have my Indian heritage as well. So where do I belong? On one end, I have my Western self. On the other end, I have my South Asian self. Where do I belong? What's my identity? And are people placing what they think about me on me? Microaggressions. And we'll get into that topic very shortly. But in AAPI youth and adults in our very diverse and beautiful cultures, we have the values of education, prestige, social status, all pure intentions, right? There's nothing wrong with ambition and wanting the best for yourself. But that perfectionism can lead to burnout. And we want you to burn bright, not out. Before I go into the next topic, so just a brief introduction, I want to thank these two individuals for sharing. Thank you so much. So, in order to combat mental health stigma, we first have to look at the reality of what AAPI and many of us face just as human beings. We're complex and we're diverse creatures. Language barriers. How many of you speak a second language at home? Many of us, right? So with mental health, we have pamphlets in English, which is amazing. But what about for our parents and their parents? Are these being produced in different languages? Even the way that we describe how we feel. Sometimes we might say, oh, I feel anxious. Other times, people might say, I feel chest pain, right? And that could be a form of anxiety as well. So there's a lot of lack of awareness and resources, but together we can be the change and we can be the voice. Most young Asian Americans tend to seek out personal network, peers and friends because of that pressure. If I talk about my feelings with my mom and dad, are they going to accept what I feel? How many of you can relate when you share how you were feeling with your parents? They might have made something for you, a dish, or maybe cut up some fruit for you. I know I did. I see a couple of laughs, right? Also, what we go through is the perpetual foreign stereotype. Ever try to explain your culture and somebody says, where are you from? No, where are you really from? And that can cause a lot of pressure and a lot of anxiety. Do you understand me? Do you understand my culture and what I have to face? A really big hot topic that have seen as a licensed professional counselor is the topic of boundaries, right? Hot topic, especially when we're in COVID, where we didn't have that physical separation that we normally do. We were all together at home, right? And so boundaries can also seem as a foreign concept in our culture because people might think of boundary as a physical space. So when we try to advocate for our needs to our parents or loved ones, they might say, "What? Do you want to move out? What?" So parents also have pressure too, right? But when we think of boundaries in terms of mental health, boundaries can be physical, boundaries can be emotional. It's the rules or limits that we set in a relationship. Any thoughts on that?
To relate to like the physical boundaries, like my I want to like for like when I go to college, I want to move out, but my mom wants me to stay at home, and like I also relate to that.
Right. Thank you so much for sharing that, especially our AAPI youth, and perhaps many of us, even now, self compassion. In fact, compassion comes from the Latin root compati, which means to suffer with. Mindfulness, right? Being present with ourselves and recognizing that all of us have human dignity. And that is truly the essence of mental health. Another aspect that we have to think about is trauma. Can anybody define for me what they think trauma means?
I think um if you can like relate it to something, I think it's like a mental version of a scar, like on a physical body, because it's something that sort of lingers rather than just healing, I think, in a psychological sense.
Great, great, great metaphor and analogy. Beautiful description. But think of it like this: trauma is any time you felt that you were not nurtured, be it any way. And with AAPI youth and adults, especially first generation immigrants coming to the United States, we also have something called family of origin. So think of grandparents, great grandparents. So there could be grief and loss, or war, conflict, or racial discrimination. And even deeper, grief is not just the loss of a loved one, grief can be any loss: loss of freedom, loss of self expression. So these are the things we want to think about just to facilitate that conversation in mental health. Also, with stigma, Asian Americans are least likely to speak up for themselves. Not that they don't want to, because of the fear and the anxiety, the use of feeling words, right? In my culture as a South Asian American, we have a phrase called lo kya karenge, which means what will people think? So parents might say, hey, when you go outside, don't forget you're representing us and how we raised you. Or in East Asian cultures, you might have the idea of saving face. Don't talk about your problems outside of the home. Preserve the family honor. Can anyone relate? Absolutely. Absolutely. Expectations, criticizing appearance or Western beauty standards. Thinking about, have you ever talked at a family meeting and your family may have compared you to your cousins, right? But each of you have a very beautiful and unique identity. Sometimes in our culture, we might have spirituality and religious intolerance. For example, Muslims and Sikhs are often discriminated against for their appearance or their beliefs. Or thinking about when you're at the store and a microaggression, you clutch your purse out of fear, right? These things can impact our mental health. The next topic is model minority myth, but I want to open the floor and offer anybody a chance to give some feedback, a comment, or a question. Does any of this relate? Awesome. Awesome. Yes. Do you have a question?
Hi, I'm a fifth grade teacher out
Hello.
here in Ailey, and I have a few Asian American students. And I feel like sometimes they go through things, maybe bullying experiences or just these same thoughts that you're discussing. but they don't express it to me as a teacher, but then it comes across as misbehaving in class or like a concern as far as their learning development. How can I, as a non-Asian American teacher, connect with that student or like talk to them about what boundaries are and what do you do when your boundaries are being crossed?
Thank you so much for that question. It's an excellent question, and I can already see your heart opening up with that self-advocacy. One of the most beautiful things about us in our human nature is we want to listen to respond versus listening to react. That openness and the willing to know about somebody's culture coming from a pure heart of curiosity. Ask open-ended questions. Expressive arts can also be phenomenal working with the children. If you ask them to draw a picture of them next to their family, you can see by the stick figures, oh, I'm noticing you're a little bit standing closer to mom. Tell me more about that. And so towards the end of the presentation, I'm going to give you some practical tips on how to facilitate that. But thank you for your willingness to advocate for our community. Awesome job. So we have another thing in terms of academia, but also in terms of career, the model minority myth. How many of you have heard of the model minority myth or can guess what it means? Yeah. Does anybody want to share their definition of the model minority myth?
So the model minority myth is used to describe API, and it's this idea that using data that we might be more high performing as a minority. There's this idea that there's standards that we need to uphold and to have that pressure to be high performing. And this can definitely affect mental health because there comes this idea that you cannot suffer because you are the model minority. Sorry, and you should be kind of modeling for the rest of the country, basically.
Absolutely. Phenomenal definition. Thank you so much for sharing. And exactly, we internalize the stress versus what we want to do is we want to externalize the stress and facilitate that dialogue. In fact, spot on the suffering and the willingness, I have to achieve, I have to achieve, I have to achieve. And what does that lead into? Burnout and self-criticism. Also, Asian American adolescents may have different values. So there's also collectivistic cultures, right? What I do affects the family versus what I want to do. For example, when I'm not doing therapy, I love art and I like to paint. And a little old me, maybe 10 years ago, wanted to go and maybe for Disney or Pixar. So I do have a side art business. But I was at a loss or imposter syndrome when I was very, very good at biology. But my husband in the background is laughing because he's very good at chemistry. So I had to have that conversation. Mom, Dad, I understand you want me to be a doctor. Job security, right? But I want to be a counselor. Kind of like the doctor for the heart and mind. So yes, we have that. My decisions also affect my family. And last but not least, how do we facilitate that dialogue about mental health in the context of stigma? Knowing that if you ask questions, that's the first step. Use people first language. This is a person with anxiety. This is a person experiencing sadness, but let them define that for you. Rather than using assumptions, you can always ask through clarifying statements. It sounds like what I'm hearing you say is just be present and allow the conversation to flow. Reinforce the purpose, create a safe place by having them define their terms, right? Encourage and talk about mental health at home. You don't have to be crazy to speak up to a counselor, a psychiatrist, a psychologist. We are always here as a community for you. We want to be the change that we want to see in the world, right? Assume good intentions. If somebody is coming up to you and they're sharing with how they feel, that's because they trust you. Also, share your personal story. Having anxiety or feeling anxious at times, it's okay. We don't want to isolate. We want to rely on each other and be that change we want to see in the world. And bring the conversation to a close by thanking them for having the courage and the humility to share.
Wonderful. Well, thank you so much, Ms. Mendez. I'm going to now transition over to Dr. Lynn, who's online right now, and she's going to talk about another subtopic within API mental health that's going to be, that's also unfortunately increasingly prevalent, but disordered eating, body image, as well as suicide. So let me turn it over to Dr. Lynn online. And are you able to share the slides?
Yes, I think so.
Okay.
Give me 1 second.
No worries.
And we visible there? Right. So I am sharing my, oh, wait, okay.
I guess we can share it on our side if that's okay. Oh, okay, never mind.
That's me. Yeah.
Yeah,
Let's
that's
see.
yours. Yeah.
Yeah. Okay. Great. Okay. Thanks. IT issues. Thanks for bearing with me. And really appreciate being here today, and also appreciate Ms. Mendez for a lot of those concepts dovetail with what I was like hoping to talk about today with respect to eating disorders, particularly, and body image in AAPI youth. So I'm going to jump in, kind of dense, try not to pack too much in, but just like a broad topic. So as a reminder, I'm a psychologist at Stanford, and I do work on the Asian mental health team, as well as the eating disorders and the dialectical behavior therapy team. I'm also involved in training and teaching and doing advisory roles for diversity, equity, inclusion stuff. So that's kind of who I am as a clinician. I do a lot of like complex trauma and identity, like everything mixed up together. And also my identity as a second generation Taiwanese American is a really big part of like what I bring to my work and the lens through which I do these things. So coming in, I wasn't super sure how familiar people are with eating disorders. So I thought I'd do like a quick drive-by. Maybe you already know this, but not general knowledge necessarily. So just when I say eating disorders, generally, we often talk about, these are the ones that we talk about. So anorexia nervosa is the one that most people sort of in their mind, when you think of an eating disorder, it's like that super, super skinny person that like never eats. But that's one that's common. There's bulimia nervosa, which is when there's cycles of binging and purging. So eating a lot and then either throwing up, having some other behavior to try to like get rid of that food or the calories or to make up for those calories. There's binge eating disorder, which is when people binge eat. And then there's a couple other ones that we talk about like less, like avoidant restricted food intake disorder, pica, and rumination disorder. And I just wanted to put a note too. I know that they sound super interchangeable, eating disorders and disordered eating, but basically when I say disordered eating, I'm just referring to the specific different types of behaviors that can be, because they happen for different reasons, like they have different functions for people. So things that are disordered eating, we would look at caloric restriction. You're like not eating, you're way cutting down your calories, or you're counting. Purging, so making yourself throw up, or sometimes people do other compensatory things like really intense over exercise or laxative misuse. There's a really alarming thing where people with diabetes sometimes misuse insulin as a way to try to manage their weight in the body, the way that their body processes calories, basically. And so there's also like people with really intense food rules, people who binge, and there's, even though this isn't technically eating, this body checking part and this body focus. So it's not super well known, but eating disorders actually have some of the highest mortality rates out of all psychiatric diagnoses, which, is pretty strange because we don't talk about them in that way, the way that other diagnoses have more visibility. And this is a combination of very serious physical medical consequences that you can, actually die from. So you can literally starve yourself to death, but also there are other things that are really impactful for your health. Like if you're purging a lot, your electrolytes are in balance, which means that affects your heart functioning. So people have like heart organ damage, organ failure, or like things that can actually be fatal. But there's also a concurrent really high suicide rate within these eating disorders. There's a significant impact on like how well people are and like how much they can engage in their lives. A lot of the times there's other psychiatric stuff going on. So like a lot of the times it's like you know, you have binge eating disorder and, you know, you're very depressed or anxious or might have OCD or PTSD. So lumped together with some really tough stuff. And unfortunately, a lot of the times, like the medical professionals who might be the first line who might like see you, like your family doctor, they're not necessarily trained to recognize when something is going on with your food eating or your weight. So why do people have disordered eating and body image stuff? There is a part where it's just like your risk is a little bit tied to your genetics, but that's definitely not all the story. So a lot of the times there is a sense of control, like I'm really anxious. I feel high pressure to perform in a certain way. This is one of the few things I can control, or like my family life is really chaotic or like really feels really terrible or punitive. This is one thing that I can control. There's a belief that people have to, like, I have to look a certain way to be accepted or desirable or, you know, like to be societally recognized, to be liked. There's this emotion regulation component, which is like, you know, I think most, if not all of us have done some emotional eating. Some of us might have done it in the past week, for example. Talking about anyone here, but there's like the binge eating part, like that's sort of using that function is food is often the thing that's available to us to self-soothe in that moment, and it works in that moment. And so sometimes that snowballs and gets a little bit out of control. There's also this way that being really, so if you're really malnourished and you're eating very little, people use that as a way to numb out from trauma symptoms, because when you are very, very undernourished, what happens is that your mood tends to be very, very low and flat, but more stable. So sometimes people actually stay there because the pain and the intensity around having the trauma when you're like actually fully, you know, fed and able to do that is, you know, it's preferable to be really flat and low, basically. And people do not get these things because it's about they're vain or they're shallow or they're self-absorbed. And I think those are some myths that people associate, they tend to associate with eating disorders. I'm not sure in terms of like my presentation, it looks like it might not be showing up. Like I can keep talking, but I wanted to like just pause and check in on whether there's anything you wanted me to do there.
There you
Can you
go.
hear
We
me?
got it back up.
Oh, okay, no worries. I can, you know, I'm happy to keep talking also, but okay. So like zooming in a little bit more, eating disorders and people of color. So people used to think that eating disorders was a white people thing, and that's kind of called the myth of the golden girl, where somehow, you know, people thought that people of color were protected because they had like other appearance standards or things like that. Totally not true. Like we now all know that eating disorders are things that people of color get. It's been seen around the world. It's seen in all different races in the US, you know, like definitely a thing. However, what that means is all the research that we've built up around eating disorders, the way that we think about risk for eating disorders, the way we design treatments for eating disorders, those have been created and normed on mostly white folks. And so what happens is there's a big chunk of like what it's like to be a person of color and live in that body that affects your eating disorders risk that's not always addressed. There are also lower rates of diagnosis, like eating disorders are under-recognized in people of color because that's not what clinicians are on the lookout for or have in mind as their like picture of someone who has an eating disorder. And as was previously mentioned too, you know, there's lower rates of treatment seeking for mental health. And so it ends up being like a pretty underserved and like under-addressed thing that people are struggling with. Going in a little bit more, and that's where I'm saying there's a lot of this that dovetails with the previous presentation, where for AAPI youth, there are some things that are particularly relevant. So pressures from the model minority myth, like if you are, you know, anything that puts you in, makes you feel like you're walking like a tightrope, you are high pressure, you need to be a certain way, or else that's something that increases your risk of eating disorders. There's also often this culture in parent-child relationships where it feels like your approval, your love, them being proud of you, or, you know, like is based on how you perform or achieve in academic or like professional things. So that's also a high pressure thing where someone's self-worth becomes tied to how you're doing there. That also raises your risk of eating disorders, and also that pressure of like appearing perfect. There's that perfectionism piece of like, I can't mess up. I have to be imperfect in every way. There's some moral components that we get baked in that like somehow appearing a certain way or being thinner or whatever is moral, like goodness is like, I have good self-restraint. I have, like all of these things that are not true, but are tied to people's perceptions of your appearance. Those really get baked in. And so if you feel like you're operating under those and you have to be that way to be accepted, people can get very focused on that. As was mentioned before too, trauma is a common thing. So generational trauma, like maybe it's, your parents' generation that immigrated from and have a lot of experiences of like human rights violations or political upheaval, or like even just the migration story, which affects their parenting style, which affects the kids. And then also youth also experience like violence, unfortunately, either from family sometimes, or, from romantic relationships, from interpersonal, or like racial violence that has been, on, as you know, with AAPI, like on the uptick in the past few years. These are all things that have to do with eating disorder risk also. If we're digging a little bit more into just the appearance part of it, hopefully I've made the case that it's not all about appearance, but if we look into the appearance part, there's also these like super intense appearance standards from culture that you might be, looking to as like inspo, like K-pop stars, places where like cosmetic surgery is like super common. There's aspects of appearance like skin tone that we talk about a lot, but is not that much discussed in like the white, whatever dominant beauty ideal here, or it doesn't have the same weight. We also talk about features, feature shape, your eyelids, is a thing, your face shape, and it can be really mixed up with this internalized racism. So like there's, for example, like valuing of sometimes more white appearing features, like having a tall nose or like having eyes of a certain size or shape. Fetishization of biracial, like white Asian people. There's also this gendered racism and how one's supposed to be. If you're female identifying, there's this like Asian women are small and delicate. If you are more male identifying, Asian men being emasculated, presented as like emasculated in generally in society, or like, and then having this thing to overcome of like, well, maybe, I push back against that and appear a certain way. And then it's really important to talk about the stuff that comes from our own communities too. So colorism is super strong, I think, in Asian communities, in these different cultural backgrounds. There's classism, there's casteism that gets passed down. So even after people migrate, they bring these social structures with them, and that gets perpetuated and placed on the youth as well. Even if you may not necessarily be the generation that immigrated. One big component when thinking about Asians and eating disorders is this family component. So a lot of the times parents have some of those mistaken beliefs about eating disorders, and or a general lack of awareness or language for it. So it might be like, oh, my child's acting weird, but I don't know what to call that, or that it's actually a serious thing. There can be a lot of blame, as in like, why are you doing this? Like, why won't you just eat? Why won't you just, stop being so shallow? Why are you eating so much? Like, like why are you doing this? This is a problem of like self-control. This is a problem with you, without the knowledge of how these things develop and are perpetuated. There's a very common thing where there are generational differences in how okay it is to say stuff about your body. So like if you grew up here, generally we like overall have internalized, like we don't say stuff like directly about people's bodies that much. It's not as much a thing. It's not as socially acceptable. It can be like, interpreted as pretty hurtful. But then, say you visit your relatives like in your country of origin, and they're like, oh, you got fat, or like you, like, why are you so dark? Or like really, really blunt and direct commenting judgments about your body. And then, you know, like when the people who grew up here are like, hey, that's super hurtful, please don't do that. There can be this response of like, why are you so sensitive? Like, this is how we show love, you know, like we just want what's best for you. Parents are an important source of beliefs of like modeling about, you know, the morality associated with appearing a certain way. So even if it's not direct like criticism of your body and your eating, how they talk about it, how they treat other people, that really gets internalized for folks. And then finally, there's these idioms of distress, which is basically like, how do you express that you're upset, like that you're in pain and emotional pain? Like as was mentioned earlier, food is basically the only love, like I'm joking sort of, but like food is one of the few love languages that certainly in my family, like we never said I love you, we just offered each other food and that's all we know how to do. And also between that and the lack of awareness about mental health, when someone's trying to express, hey, like I am hurting, I am in pain, I need help, often if you're trying to express it to like a parent who has less knowledge there and you're like, I'm super depressed, I'm super anxious, that gets discounted or it's not taken seriously. So sometimes this thing I've seen is that young people will come into the eating disorders clinic, young Asian people, and I'll start like saying, hey, what's going on? And they'll tell me something that sounds pretty minor, like, oh, sometimes I skip lunch, which is a pretty common thing and wouldn't necessarily fit a diagnosis for eating disorder. But when I talk to them more, it's actually, I'm actually super, super depressed. I'm hurting a lot and my parents can't hear the emotional part. And so the only thing that communicates to them that I'm not okay is something that's physically point outable, like my food, my eating, like I'm not eating well. So this is a thing that I feel like I need as a way to communicate to them that I'm not okay. So mindful of time, very quick drive-by on some intersections that it's important to address. So with gender, you're probably aware that like eating disorders are by and large diagnosed in female identifying folks, but absolutely people of all genders get them. There is an increase in rates, in fact, of like non-female identifying folks getting diagnosed with eating disorders due to both an increased awareness, so people are looking for it, and an actual increase in rates. So that's pretty worrying. For queer folks, LGBTQ folks, there's some really important intersections there because again, things that place stress on you, place you in danger, things you're experiencing like homophobia, transphobia, racism, they all increase your risk of eating disorder. And these folks are at increased risk of violence, like suffering physical, literal violence. And also in the case of trans folks, so if you're thinking about an adolescent who's transgender, going through puberty, you're starting to develop these secondary sex characteristics that are really aversive because they're not how you think about yourself, and they make you incredibly uncomfortable and not okay in your body. One of the ways that you can slow that down is to stop eating. So suppressing your nutritional intake slows down puberty and the development of those characteristics. So sometimes that ends up happening. And finally, you know, this suicide piece, which is really heavy, but something that kind of haunts our entire community because it comes up so often, unfortunately. So I'm going to spend the last couple minutes going over this a little bit, just touching on this. So as I mentioned earlier, suicide is super common in eating disorders, but also is a big problem, second leading cause of death for AAPI youth. And it's something that has been really painful and troubling for the community. And there are a lot of commonalities in the things that increase your risk of eating disorders and the things that increase your risk of suicide within AAPI youth. And there's a lot of overlap there. This is also something that's particularly close to my heart because like I grew up in the Bay Area here in California, going through like a really it's a high Asian population and there are these high schools that are incredibly intense academically. Pressure is really high, expectations really high, and there have been a string of suicides by high schoolers in the area who are Asian. a lot of the times due to overwhelm, to academic pressure, to feeling like, hey, I didn't get into the right college and I can't be accepted, I won't be loved, like this is the end of my life. So these are places where, again, that model minority myth comes up again. This achievement focus and this common social comparison of like, oh, why can't you be like so-and-so's kid? Like, why aren't you like that? Parenting, sometimes parenting styles can be more authoritarian or punitive. So like parenting that disempowers the kid, like you're not allowed to make decisions and you don't have the agency or competence to like make decisions. Sometimes there's very like harsh parenting styles where there's a lot of punishment, but there's not a lot of like affirmation. And then there can also be more of this emotional coldness or neglect or lack of room for having an emotional experience. And then this mental health stigma, which means that people often feel like they can't ask for help when they need it. And when they do, it's not heard or they're not able to actually access it. So to wrap us up, eating disorders, like definitely a thing that happens in Asian American youth. There are multiple aspects of this identity that may affect your eating disorders risk. It's a very serious health concern, and so folks should increase awareness. There's definitely a need for increased awareness of how to recognize and deal with it in the community, in medical professionals, and also within yourselves so that you can recognize if something like this is going on for you. All right. Thanks very much for being here today, and look forward to your questions later.
All right. Thank you, Dr. Lin. And last but not least, we're going to turn over to Dr. Yen, who's going to show us practically, we talked about from Ms. Mendez earlier, right? The psychosocial issues behind why there's so much mental health issues in the API community, and how to talk about it. We also heard from Dr. Lin about disordered eating and body image, and as well as suicide issues within the API youth community. And so now we're going to go to Dr. Yen to talk about, from an expert psychiatrist perspective, what are the signs of when we need to go seek mental health care, right? So to practically apply what we've learned about all these issues to when do we seek care for our mental health issues. So we're going to pull up the slide in a second.
While we're doing that, was I the only one who thought the takeaway slide looked really delicious? I think I'm just hungry.
PowerPoint suggested it, and I was like, I'm definitely choosing this one.
I was like, oh, that all looks really good. Maybe I should go emotionally eat after this. Okay, so as everyone has heard already, I'm Dr. Yen. I'm a child psychiatrist, but I also treat teenagers and adults. I'm actually what's considered a 1.5 generation, so I came before the age of 10. My family is also Taiwanese, so Dr. Lin and I have something in common. She probably speaks better Mandarin than I do, though. So, but I wanted to just talk about something that I think is very hard for a lot of API, the community to talk about in general, both on the patient side, but also on the family side. I encountered this on a daily basis, and a lot of times it just takes so much to get them in the door. And, what I'm hoping to do today is just to kind of show you how to reach out and ways that you can try to approach the topic before it gets to a point where you come out of a hospital to see me or see another psychiatrist. If I can get the slide to move. There we go. So, this is the fancy academic slide that tells you what I'm going to talk about. But basically, I'm just going to talk about, well, when do we need to do something more than just talk to friends or family or, religious people in the community? Like, when do we need to look for someone who maybe has more training about this, and talk about some of the reasons why people don't get care when they first start noticing that they're not doing well. Talk about some of the things that I see on a daily basis, and that that counselors also see on a daily basis, and just to kind of give you a sense of like, it's not just people who are suicidal or people who have eating disorders, but it's a lot of things that we treat. And then talk about the different types of and different levels of mental health care, because I think a lot of people either think, well, you either do medicine or you don't do medicine. There's nothing in between, right? Which is what makes it so intimidating. But the reality is there's a lot of different ways you can seek mental health care. And there's a lot of different types that you can combine together to make things work. And then talk a little bit very briefly, because I could do a whole day session about treatment options, but talk about kind of things you can possibly get in mental health care and how to look for it. So a lot of the first question I get from people in the community when I do talks, or even people who are in the school system or in other health, mental health or health kind of professions, is how do I tell a patient that they need more help? Well, a lot of times it's the first one is they're not getting better. You've tried all the talking. Let's say you have a lot of anxiety about, and pressure about school, and you do your best to like self-care. That's the new big thing especially for Gen Z. Like, we love our self-care. Right? So go home, you do yoga, you like paint your nails, you emotionally eat, whatever mechanisms you have, but you're not getting better. If anything, you're getting worse. Right now, you can't focus in class. Now you can't sleep at night. Now you're spending hours and hours trying to do homework, but your mind keeps going blank. You get to a test and you just like completely forget everything that you thought you'd spent 3 hours studying the night before. So it's not getting better, even though you're doing everything you can to make it better. Your quality of life is suffering. So not just sleep issues, but like, let's say that you used to really enjoy music, or maybe you were a big fan of making K-pop cover dances. You're not doing that anymore, or that doing it feels like a chore. It's not fun anymore. You don't want to be around the people that you love the most, like the friends that you used to hang out with all the time that you would go and eat with. Like, now it's like you don't want to hear from them. It's horrible to see a text come through from them. You don't want to answer a phone call. You're not keeping up with the things that are things you have to do, whether you like it or not: work, school, family obligations, or like even your own medical appointments, taking care of other parts of your health, that you're just not doing those things. And you feel like you're just breaking down. You're, even when you do sleep, you wake up feeling tired, or you have a bunch of stress dreams and nightmares. I know I've had it. You're not eating properly, whether it's too much or too little. You're not able to feel like energetic. Even if you get 14 hours of sleep, you're still tired all day long. You start to get all those aches and pains that you never had before. You're getting sick more often. There's a lot of things that can tell you that your physical and mental health are tied. So, if your physical health is going down, there's a good chance your mental health is probably connected. And then, of course, the worst case scenario, you start to feel hopeless. You start to feel like nothing's going to get better. What's the point of trying? Maybe I'd be better off if I just don't wake up the next morning. So they don't necessarily have to be thoughts about, oh, I'm going to go into the kitchen and take this knife and cut myself. It could just simply be, I don't want to keep trying. I want to give up. I don't want to do this anymore. What's the point? So one of the things I hear a lot when people come in and talk to me is, the first thing I hear is, I don't need to see a doctor. I'm not crazy. Okay. And I think that's one of the parts of the stigma that we see in the API community, but honestly, in general, across the board, mental health stigma includes this phrase. And I see it a lot in other, minority cultures as well. It's not just API, but since we're at an API summit, we're going to talk about API. But, the reality is that mental health care and treatment is for everyone, right? We all have heard to some degree about the mind-body connection. Your physical health and your mental health are very much connected. It's all one piece. It's all in one body, right? So if your mental health suffers, so does your physical health. And the thing that I always try to tell people that is very important is, just because you can't see it, like it's not a broken leg, it's not your hair falling out, it's not like acne all over your face, does not mean that you're not sick. Okay. And that's really, really important to get across, because I think a lot of times, especially in an AAPI community or, a minority community, that's how they perceive illness, right? And then there's 3 types of care, what I like to say kind of are broad spectrum types. There's prevention, right? The things that a lot of times we call self-care, stress management, learning how to communicate with people so that you can convey your needs or express what, your concerns that you have, how to manage conflict, right? But then there's also treatment. So when you're already in a state of need, addressing things like past trauma, for example, or having coping mechanisms to deal with stress, or in some cases, medications for whatever is going on with you. And then the recovery treatment, which actually involves making sure that you're monitoring and continuing to care for yourself in a way where you are actually progressing in the right direction. And that may mean, getting involved in other programs that have additional support. And it's about learning how to identify your triggers. So those are all part of mental health care. But the idea is that no matter what we decide to recommend or what you decide to seek, the whole point is to get you to at least what you were doing before you started to suffer. And if anything, better than where you were when you started, right? Because obviously things happen that got you to this point. So we want to get you past it and give you the opportunity to do even better in the future. So let's say that you're like, okay, so maybe I'm not crazy, but maybe I still need to see a doctor, but I don't know. Well, let's talk about it. So obviously we've already touched upon all the presenters have talked about social and cultural stigma, right? This perception of, well, what, if you're seeking mental health care, you must be weak. You don't have a strong enough personality. You're not a good enough person, right? And you're embarrassing the family. Like, you can't bring shame to us. You're talking about our business. This is oftentimes a reason why people don't talk. There's also a lack of understanding about what it is, as we mentioned before, because you can't see these symptoms. You're not seeing pain. You're not seeing bleeding. You're not seeing, something sticking out of your leg. It makes it harder to explain to people who have never experienced mental illness, right? Or experienced that level of distress, right? So saying to somebody who's just had some, stress and they felt sad for a bit, it's hard to explain, well, what does clinical depression feels like? What do you mean you feel depressed and it never gets better? Like, it's very hard for people to conceptualize, right? And then just not being aware that you can actually get treatment and there's more than one type. There's also, of course, I have had this happen, and it's something that I don't think most people think about, is a lot of people get concerned about, well, what does it happen if, does this go on my record? They don't understand mental health care is just like any other medical care, right? Like, you're not going to have an employer be like, oh, I saw that in 2019 you got 5 months of therapy, you're not hireable. That's all confidential. These are not going to come back to haunt you, okay? You're not going to be unable to get a driver's license because you have ADHD. Although if you have really bad ADHD, you probably shouldn't be driving. But like, even if you end up in a hospital, like, that's information that you cannot access unless you give consent or in a very specific legal setting, like you go and you seriously harm someone. Those are situations where maybe that might come up. But this is not something that people are going to find out about just simply because you went to seek care. Access. Obviously, we're talking about a large group of people who, many of whom are immigrants. So even if our teenage patients or our child patients, they can speak perfect English, their parents often can't, or if they have family members who can't. And there, we know that when we are in a minority population, our family isn't just our parents. It's our aunts, it's our uncles, it's our grandparents, it's the family friend that we've known for 15 years. Everyone is part of your business, right? So if there's one person who doesn't understand, suddenly you can't go seek care. And then there's obviously the fear of medication. It sounds, because I think there's a lack of understanding of what they do, connected to people not understanding that it's an illness, that's a physical illness as well. So the other thing is, they're like, well, okay, let's say I go see the doctor, but what if, like, they can't even help me? Like, what are they going to do? What are they going to do when I just feel stressed all the time? How is that supposed to help, right? Medicine, I don't have a stress medicine. No, I don't have a stress medicine. If I did, we'd all be happy. I'd also be a billionaire, but that's not the case. We don't have that. But there are concerns about seeking other types of care, right? So there are a lot of interventions, especially in the Asian community, that people love to go to. That are complementary medicines, but some of them are not very consistent, and some of them can be harmful in the long run. So things like acupuncture, cupping, and they have some consistent effect, but it's very person to person, right? And there's also, I think one thing people don't understand is there's a big difference between mild symptoms and severe symptoms, right? and I'm not going to pass judgment if you believe this, but the chances of chemotherapy medications working for cancer versus acupuncture for cancer, there's a big gap there, right? So there's some things that you just don't want to chance, right? Because getting worse because you didn't take the time to go and seek treatment early on. And the reality is that natural is not always safe. And that's something I have to kind of really keep hammering home with a lot of my families, is that just because it's over the counter, just because it says it's a plant or, an essential oil or whatever, just because it's natural does not always guarantee that it's safe. Okay. You can overdose on vitamins. You can literally end in the hospital from taking too much vitamins. So anything when not used properly or used in excess can be dangerous. So I always tell people to keep that in mind. And the reality is that a lot of these natural interventions, even the ones that we have some research that shows it works, it takes forever. So imagine being super depressed for 6 to 12 months. You finally go see someone for acupuncture and they tell you it's going to take another year before you feel better. Do you really want to be in that state? That's really miserable, right? Now, on the other side, therapy and medications have been extensively studied, and that's because that these are, considered like scientific methods, and so they've been tested, retested, over decades of time. They are designed. Different medications, different therapies are tailored to what you need them for, different symptoms. There's a lot of safety and efficacy data. Now, I'm not saying they're perfect, and I'm not saying that everything's going to work for everyone, but there's a lot more research behind it. And we know that it tends to help boost the recovery and make you get back to better your old state faster, right? And you have it from people who are trained to do these things. So some of the common things that I see in office, and it's not an exhaustive list, but these are the most common that walk into my door: ADHD, autism. So you don't treat autism as a diagnosis, you treat the symptoms and the dysfunction that comes with autism. Let me rephrase. Depression, anxiety, PTSD, which is technically part of anxiety, bipolar disorder, which involves a lot of mood swings. We also do schizophrenia or psychosis, and then of course substance abuse or addictions of different kinds. So that can be gaming addiction, that can be substance addiction, that could be eating addiction. There's a lot of different kinds of addictions. And then other things that we also address as like a broader picture is trauma and the various issues that come up with trauma, abuse or neglect, which kind of folds into trauma, acculturation conflict, which a lot of people don't think about. But I see a lot of cases where parents bring their kids in because they're like, I want you to make my kid behave. And the reality is it's a lack of understanding between the generations. So some of what I do is actually just helping them communicate better. And then relationship conflict, and that can be with your friends, that can be with your family, that can be with a romantic partner, but there's a lot of things that could be involved. I don't want to take medication. I hear that every day. So sometimes from the parents, sometimes from the kids. So this is where it's important to know there are different levels of care as well. Medication is not the only option. And actually, there have been times where I have told patients that I've seen in the office, I don't really think you need meds right now. So it's very individualized, but there's also family interventions or group or community interventions. And then there's school-based interventions as well, so that don't involve medications. And there's also lots and lots of different types of therapy, which I'm not going to touch upon because there are better qualified people who could talk about it later. So if you have any questions for them, I think you can talk with them after the fact. And as you can see, there are lots and lots of different types of professionals who get specialized training to help you in different ways, right? And we obviously do tailor all of your care based on what you need and what you're coming in for help for. The other thing I get a lot of concerns about, at least on the medical side, is they're like, well, okay, yeah, well, I did kind of tell my mom, or I wrote a letter in the school saying that I wanted to commit suicide. So now they're just going to put me in the hospital. Well, no, our goal is to not put you in the hospital, but sometimes that is the most appropriate thing if you are at that kind of level of need. But we have different types of settings, right? We have outpatient, which most people know as kind of the medical offices where you go to the office, the clinic, but there's also school-based where you have school counselors and interventions. You have support groups, people who go to like 12-step programs are considered, that's an outpatient type of care. Hybrid systems where you will go to like a very intensive outpatient program that involves medication and therapy, but at a hospital, but you get to go home at the end of every day. Same thing with partial, it's a little bit more advanced. And then of course there's the inpatient option, which is the hospital setting, or for some people who need longer care, residential. The idea is that anytime you see any of us providers, but particularly for medical professionals, my goal is to figure out what kind of care you need and what level, what intensity, right? And that's going to be based on me talking with you for an extended period of time. And if you happen to be younger, also with your family. And then your hospital. And the thing I want to make very, very clear is that unless there's a very specific circumstance, we can't force you to go to the hospital. Okay. So I want to make sure that if you're at all worried about that, we don't. It's very difficult to make someone go to a hospital against their will. There's a lot of rights and laws and legal things that protect the patient. So we will typically work very hard to tell you why we think it's important to go to the hospital, but we are not going to lock you up in a hospital against your will unless it's under very, very narrow circumstances, right? If you're a danger to someone else, you're a danger to yourself. Those are the circumstances where we could potentially request that. And even then, you're not there for the whole time. Like they always try to test and make sure, and they check in with you to see, are you at this point able to transition to voluntary? But so the hospital is our last resort. So what are some of the ways that we can help? And this is kind of where the treatment pros and cons happen. And I just skim over it because there's a lot of words on the page. And it's almost lunchtime, so I think everybody's thinking about food. But there's different therapies, right? There's supportive therapy, where it's kind of what we consider like the traditional ones you think about when you see on TV, where you talk to somebody, you vent, and the therapist is like, "Oh, that sounds really terrible." You know, they don't necessarily offer a whole lot of interventions, but they're there for you. They're a listening ear. There's also psychoanalytic, which is the one you hear about when you think about Freud, and like everything is your mom's fault. That's the kind of like the psychoanalytic. Psychodynamic means that there's a variety of different methods that are chosen and put together. Cognitive behavioral, those are the ones we use for things like depression or anxiety and are very, very well tested and shows very helpful. Trauma informed, meaning that they are very sensitive to the fact that your symptoms are related to your trauma and how to fix that. Exposure response is a special type of treatment that we use for things like OCD, when people are afraid of germs or afraid of cracks in the floor. Like, how do you help with that? There's also that individual, family, group, community level type therapy. And they're great. And the thing about therapy is it's great for like situation specific issues. Like if you're having work stress, if you're having performance anxiety, if you're having family trouble, communicating with your family, that's great. Therapy is great for that. And I would first go to this before I do anything else. And I would recommend that. It's also great for people who just can't take medication for whatever reason. Maybe they're on 15 already and they just have too many interactions. Maybe they just have their liver doesn't process medication properly. So there's a lot of reasons why therapy might be the first line and not medication. But some of the challenges include, and this is some of the things I see all the time, for an effective therapist, you need someone who can understand your language of origin, especially if you don't speak English. Okay. Because think about the number of turns of phrases, idioms, expressions that we use, the slang that's used. I mean, just imagine what it's like trying to talk to your parents in your generation slang. It's like a foreign language, right? So if they can't understand that and understand why you're choosing those phrases, it really impacts their understanding of you, which makes therapy less effective, right? Scheduling. The reality is that most of us work 9 to 5 or you're in school. 8 to 3 or 8 to 4. And so it's hard to schedule. And therapy is most effective when you're doing it regularly, once every week, once every 2 weeks, sometimes even more frequently. You don't get much out of therapy if you're only going to see your therapist once a month. Think about seeing the friend that you talk to when you vent only once a month. Think of how much time you would have to spend to catch them up on just that one whole month of things that happen to you. So how you can't really make progress that way, right? And then, of course, if you have someone who's developmentally delayed, if they're, mentally kind of younger, it's hard to have some of the types of therapy that we use. And then the cost and access, medications, there are great things about medications. There's different medicines for different people for different things. And we can use one medication, we can use multiple medications. And as long as you're doing it under the guidance of a trained medical professional, it works really well for a lot of people. But, and it does address a lot of the more severe things that you can't fix with therapy. When you have someone who's coming in and they're actively wanting to kill themselves and they're not sleeping, they're not eating, they can't function, medications can be very helpful to kind of essentially jolt you out of them and kind of get you back on track. And it does improve symptoms a lot faster in many cases. You can also combine it with therapy. So it's a great kind of combo thing. But some of the challenges, obviously, people, like I said, people don't always take medication well. Some people are very sensitive. And I happen to know for a fact, and there's a lot of research behind it that says AAPI individuals are more medication sensitive. We tend to be more sensitive to side effects at lower doses, but it also means that there are many more that make it hard for us to get to take. But when we find one, we can still get it to work. And you have to keep taking a lot of these. Most of them you can't just start and stop whenever you feel like it. It's very hard for me to explain to parents and even to my teens, well, just because you feel better doesn't mean you have to stop taking it, because your medicine is probably helping you feel better, right? It's like that whole thing you hear from all your doctors. If they give you a 10-day course of antibiotics, they always say, what? Take all the pills or you're going to get infected again, right? And it's hard because you usually feel better before you finish your pills. So it's the same thing. And cost and access is still going to be an issue here. So I'm going to kind of just briefly go over this because a lot of times people don't know this information because we work a little differently than other doctors. So I'm just kind of talk to you about it. Your first appointment with a psychiatrist is going to be the longest. It's not a 15-minute medical check. It's a 60-minute, 90-minute full-blown interview. And that's because they really have to understand what's going on with you, right? You can't cover your entire life's history in 15 minutes. You can't even cover it in 60 minutes, but at least we can get more of an understanding of what's going on with you. If you're looking for help for your child, or if you are a child or a teenager, you're always going to be asked to be there. I have a lot of parents, especially AAPI parents, who are like, can I just come in and talk to the doctor and basically complain about why my child isn't doing well? But I don't want my kid to know, so I'm just going to come in. That's not how this works. I can't treat your child if I don't see your child. I have to be able to interact with them. I have to be able to have a conversation with them. I have to figure out from their perspective, what the problem is. I can't just take your word for it. So you have to bring the child in. The other thing I always tell all of my, especially my older children, the teenagers, preteens, and my parents is I will at some point ask to speak with them alone. And that's just because no matter how close you are to your child, or how close you are to your family, there's always things that you keep from them, right? Every one of us has been there. We all keep things from our family. They can be small things, but they can be big things. And it's important for me to be able to know what those things are, because that can make or break what I decide to recommend, right? And I always tell the parents, and this is the hardest part, I tell the parents, I will not tell you what your child is going to tell me. This is very important, partly because how am I supposed to get your trust? If think about it, if you have a friend who tell them a secret and they turn around, they'll tell the person that you told the secret about, you're never going to talk to them again. Same thing goes for these visits, right? And so I tell my parents, if it's something that will seriously impact them, put them in danger, impact your family, I will tell you. But everything else stays between me and the person I'm talking to. So I want to make sure that you understand that if you have a well-trained therapist or psychiatrist, they will not tell people what you're telling them in session. They should not. Okay. If they say otherwise, that's a problem. I would actually recommend you move on. So now, obviously, with the younger kids, I keep mom and dad in the room the whole time because they're young and they can't tell me a whole lot. But older kids, I will give them that time. And then at the end of that interview is when you get to the treatment part. This is the part where the doctor will say, okay, this is what I think is going on with your child, or with you if you're the one seeking care. And this is what I would recommend. Now, it can be medication, it could be therapy, it could be both. They should and be willing and should be able to explain and answer any of your questions about reasoning. Why are they recommending this? What is this that they're recommending? What are some of the potential benefits? But what are some of the risks? In a medication case, what are your side effects? What are some of the things that I would want you to watch out for that you need to call me back about if you have any issues? You want to make sure also that, the person that you're talking to, you're comfortable talking to, and they're not just being like, well, just take this prescription, go fill it. I'm not going to tell you anything. You need to be comfortable, because one thing I will know that I can tell you about AAPI patients is they will tell you, yes, 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 go home and just not do it. Okay. If they don't feel comfortable, I could tell them anything I want to tell them. They're going to go home and they come back and lie to me and say, oh, yeah, no, I've been giving the medicine every day. Kid is not taking a single dose. And I'll find that out from the kid later. That no, my mom said I can't take it. It's too dangerous. So, I make an effort to like explain everything. So please ask questions. That's what we're here for. That's what we're trained to do. We want you to take the medicines. We want you to get better. So if you have any hesitation, explain it to us. Tell us why. We're open to hearing it. And of course, we're going to talk about, do you want outpatient, inpatient, why we would do that? Okay. And then also we're going to explain to you how often we need to see you. Why do we need to see you that often? Are there blood work that we need to take care of to make sure that we're monitoring your safety? So those are all things that we would discuss. After all that, and let's say you decide you really want to see someone. You don't know where to start. Well, there's 3 really great ways. The first one is reaching out to your primary care or your family doctor. A lot of times your primary care doctors have referrals to people that they work with or they like, and they have gotten good feedback about. And a lot of times if you have like an HMO where you can't just go to any doctor you want, your primary care has to make the referral anyway. The second option is to contact your insurance. And the reason why I say this, even though it's kind of painful to do this, and I've contacted my insurance, I can tell you it is not a fun process, is that they have an active list of who they will pay for. Okay. Which is very important because it's costly, right? And so you want to know which doctors are you going to be able to go to see, and your insurance is actually going to pay for them, right? Because if you go after the fact, you're going to be responsible for that cost. The third one is if you're uninsured, what do? Well, you can still get care. There are lots of nonprofit organizations and in clinics that will take you in and provide care because it's important. And we want you to be on your feet, and we want you to be able to go out and get your job and get that insurance, or to help you apply for different types of insurance. So there is always a way. At the Harris Center, we even see patients who are undocumented. We will not turn you away. If you need care, we'll take care of you. So keep that in mind, is that don't let the fact that you came here, illegally or under the books keep you from getting care. Because a lot of times I see that with a lot of our immigrant populations. There will always be organizations who will help connect you to the right people who will provide you that care. So please don't wait to get care just because you're worried about that part. Okay. And then the last part is the one I just kind of wanted to re-stress. How do I know I'm with the right person? It's like a good relationship. Okay. Not everyone's going to work for you. Everyone's personality is different. All your doctors are different. Their styles are different. It's okay to say, I tried this doctor and I just don't vibe with them. I don't really like them. They make me uncomfortable. I don't feel like I can tell them the truth. I feel like they're pressuring me. If those are all things that come up, you don't have to stay with them. Find someone else, because mental health care is hard enough to engage in. Don't find someone that you don't feel like you can continue to work with. Okay. This is a relationship just like any other one. If they're not a good fit, move on. Okay. And I would encourage you. I tell all my patients that. I mean, I'm like, I think I'm pretty likable, but if there's something that we talk about, you don't feel like you're comfortable talking to me, there are other doctors who are great in the clinic. I'll be happy to refer you. I'm not going to take it personally, because at the end of the day, I want you to get better. And if I'm not the best person to do that for you, I will help you find someone who can. Okay. So don't take it personally. If they take it personally, then that's not a good fit for you anyway, because they shouldn't be taking it personally. It's their job. So if in doubt, if you have a question, ask. Okay. And this falls into the whole, if there's no stupid questions thing, ask. I don't want to find out 3 months down the line that you watched a TikTok on some natural treatment and you were afraid to tell me, and now suddenly something's happening with your medicine. I didn't know that you had added this thing on because you didn't ask me about it, and now you're in the hospital for some sort of allergic reaction. So talk to me and talk to your providers. We want to know. We want to know what's going on with you. That's how we help you, right? And the main thing is just to say that, if you don't like the person you're with, the one thing I do want to say, the caveat is you can find someone else, but don't stop care until you transfer to someone new, because some care is still better than no care. Now, obviously, if they're not treating you correctly, they're refusing you to treat you, or they're refusing you medication, that's different. Okay. But if you're on medication, you're in therapy, even if you're not 100% comfortable, don't stop, because it does take time to find someone new. Unfortunately, it takes weeks to months to find a mental health professional. You don't want to go that long with no treatment, right? Especially if you've started and you're starting to make some progress. Even if it's not perfect, stick with that person until you transfer. And that's it. So thank you for listening. I hope that was helpful. This is my contact information. But I know that there's lots of also great clinicians here and resources here through the summit. So I encourage you to take advantage of them and to ask them any questions.
Wonderful. Well, thank you. A round of applause for our 3 panelists. I think we have a few minutes for questions. Does anyone in the audience have any questions that you all want to ask? Anything, questions, comments, anything to clarify? Because I know we talked about a lot through these 3 presentations. Yes. I'll hand over the mic here.
So my question's for all 3 of you, right? So why is it mental health has become more common just in the past decades, right? We humans exist over thousands of years. We function perfectly fine. I wouldn't say perfectly fine, functionally fine over thousands of years. Why is it just becomes more common?
Go for it.
Well, I was just going to say, so the way I try to explain it is the way that we've suddenly had a burst of new diseases and new conditions. It's not that it wasn't there. It's that we didn't know what it was. Okay. If you think about it, we didn't know what diseases were just a few hundred years ago. We had no name for diseases. We just knew people got sick and died. We didn't have medications. We didn't have therapy. We didn't understand the mind. So it's not that it wasn't there before. It's not that mental health didn't exist before. It's just that we didn't have the terms for it. We didn't have the understanding of what that was and what that encompasses and what it means to be mentally ill. So if you think about it, and this is, I think, something that you still see as a remnant of a lot of AAPI communities, is they equate mental illness with physical illness, right? It's, I can't sleep. It's not because I'm stressed out or anxious or depressed. It's, I can't sleep. We can't quantify it in physical ways, but it doesn't mean it wasn't mental health or mental illness to begin with. It's just that we did not have the words to describe what we were feeling or seeing. So, people who, it's the same reason we had those people who had psychosis, who had hallucinations, who had paranoia. Those people weren't, mentally ill. They were witches, right? They were sorcerers. They were evil. They were possessed. So we've always had words to describe what we were feeling or seeing, but they just weren't the words we use now, which is mental health, mental illness, depression, anxiety, bipolar disorder. So those things existed. It's just that now we have definitions.
That is such a wonderful explanation. Testing. Oh, thank you. Yeah, that is such a wonderful explanation. And to build on that, it's kind of like when you're investing, right? So not just money, but you're investing time. And similar as mental health counselors, what we do is we'll do an initial intake and we're going to make a treatment plan. A good therapist is always going to ask you for feedback and especially ask for questions, right? If your therapist is not being honest with you, that is a red flag. And we want some green flags. And also culturally competent care. So you can always ask us questions. You can also find intersections in your identity as well. So for example, I do offer faith-based counseling as well that will take into consideration of personal faith and or spirituality, as well as mental health. Both can be intersected, most definitely. But how will you know if you don't ask, right? So definitely, we're here to help.
I was hoping to jump in with like a last kind of thought about that too, which is that I think as Dr. Yen said, like it's been there, but there's a really difference. We sometimes, it's cheesy what we say, like surviving versus thriving. And a lot of the times, the things that have helped humans survive over time like, where does anxiety come from? Where does fear come from? You have a good instinct to see danger, get out of the way. If that's actually like a physical risk, that's actually adaptive. So there are ways in which those mechanisms get out of control. Like right now, a lot of the things that trigger anxiety for us are not literal physical, like life risks. So there's a function to them, but they're getting triggered also by aspects of modern life that's not serving that function and it's not serving you well. But also humans have persisted. The things that make you well are not the things that make you literally able to survive long enough to have kids so that they can have kids. Like, if that makes sense.
Wonderful. Great question. Any other questions from the audience? If not, I have a question or two I can ask. I just wanted to for sure give precedence to the audience. Yes.
So, spirituality, religion can be a complement, a source of strength for certain patients, as well as Eastern type of medication or interventions. If you start, however, noticing that it's actually becoming harmful, or patients are using that more than what your interventions are and what you've trained for, then how do you address that with respect to their culture too?
That's an excellent question, Tuan. And I know that that's a work that you and I are both passionate about. So I really appreciate that. I always want to have the client define what it means to them, right? So for example, I'm South Asian, but I'm also was born here in Texas versus my parents' generation. And I might be working in, let's say, university settings or in nonprofit work, and I meet another person and I'm like getting reminded, right? So I also have to be mindful in what we have a term called countertransference, right? Just because I assume this, I have to let the client define it for me. And so allowing them to define that, but then comparing it with the DSM, but then which is our diagnostic statistical manual, but then again, how does the West treat mental health versus how we in our own cultures treat mental health and facilitating the dialogue. So in essence, having the client define what that means to them and through use of open-ended questions and always collaboration, consistency, and compassion.
I think it's also really important not to set up a dichotomy like between, you know, kind of having faith-based interventions and because a lot of the times it can be really dismissed. And what happens when you treat something with contempt or dismissal or like that's not science is that people aren't heard. So a lot of the times too, you can find allies within the faith communities, like faith leaders who are like, this is how this type of treatment integrates and can coexist well within our belief system, within the values of our belief system. And so clarifying this for people and then instead of being sort of dictating, just like kind of laying them out, you know, this way of being where those things can be there and they can know what's important to them, I think tends to be more helpful in my experience.
I think to the point of at least the medical treatment side, I tend to have a very collaborative approach with my patients and my families. So as long as it's not, usually I think with things like faith-based interventions or things like external cupping, acupuncture, things where I know they're not necessarily unbalancing things within their body or that might interact chemically with what I'm doing, I don't discourage that. If anything, I say, you know, if you feel like they've been helpful, just please keep me, you know, in kind of looped in with what you're doing. And before you try something new, at least let me know. Okay. Because if I feel like it's not going to interfere with what we're doing, I don't have a problem with it. And if anything, maybe it's something I would like to read up on, or maybe I'd like to get feedback from you about. Maybe if it's working, great. Right. So, but the only time I say that it doesn't work is, you know, if I feel like it's going to interact, I say, look, you're here to see me for a reason. I want to help you. But in order for me to maximize what I'm doing for you, it may be important short term for you to stop everything else and let's focus on what we're doing. That's not to say we can't put things back in. but just for partly for safety's sake, but also partly so you can see how this medicine is really working, that you don't say later on, oh, I think the medicine was the problem. I want you to be able to say that without having all this other stuff, all this other filler, all this other noise, right? So in the short term, let's work together. Let's focus on what we're trying to do here. And then if we can fold other things in, we'll fold it in. So I always keep a very open and collaborative effort. I definitely, like you said, I don't dictate what they can and can't do, but I encourage them to be honest with me so that if there are concerns, I can then bring them up to them honestly and let them decide.
All right. Well, thank you guys. That's the end of our time. So thank you all for listening, and thank you too again, once again, to the panelists. I think there's a lot of mental health issues within the API youth community, especially. I think the pandemic has exacerbated a lot of the issues. You know, anti-Asian hate, isolation, and so we want to move forward of going from being reactionary with mental health issues in the API community towards being proactive. Um, and yeah, so thank you all for attending. I think we're gonna have our closing session downstairs, so we can slowly move our way down there. And last but not least, on a lighter note, because I know this is a heavy conversation, go Texans for those of you guys that are football fans. So but thank you to the panelists, and especially thank you, Dr. Lin. I know you're joining us remotely, and so we appreciate you taking the time